can I introduce Luis Salvador-Carulla to give us his presentation.
Thank you very much. I am aware of the time constraints, so I will go quickly through this presentation. First of all, I would like to acknowledge my colleagues from Spain and Norway, and from other organizations in Australia. We are trying to develop a knowledge base that can answer some of the questions related to service access monitoring in the area of mental health by developing what I call the Global Local Mental Health Atlas project, where we are trying to collect information in a standard way throughout the world and try to learn from the experiences in other places and how we can improve our services locally. Oops, this goes, all right. We have a huge amount of strategies, white books, ways of working at the mental health, rural health. And one of them is this TAM's proposal, the essential components of care framework, where they just say that rural mental health services require a special consideration and special planning approaches, that we need to have a wider understanding of the social determinants and the precipitating factors like the changing socio-demographics, the environmental change, the economic constraints that are related to mental health in the rural areas. We have to correct inequities, and this is a major point. What means inequity when we are talking about rural mental health? What is the relation between urban health and rural health, or it's another question? And I will try to answer that at the very end of my talk. There is a special attention to ensure appropriate policy, planning, and service development at the rural area, adequate consultation with expert service users and providers in the rural areas, mapping. That's the focus of my presentation, and understanding how we can encourage specific peer support, the bicultural professional positions, and the retention of the professional staff in rural areas. And this is related to my major concern when working on evidence-informed planning and the type of evidence we need for policy planning in complex areas like mental health. It has been given for granted, and that's part of the framework of evidence-based medicine, that once you generate a wonderful evidence, you just have to implement it in the real world. But this never happened. When you try to apply our wonderful meta-analysis to real policy, you find that there are many gaps. And the problem is that implementation happens in a context. Either we know the context properly in a comparable way, or we will never be able to implement the evidence in the real world. And it's quite striking, but the area of context analysis is very recent. It was just in 2014 when the Health Foundation in the UK published Perspectives on Context, the very first seminal report on the importance of context to understand the translation of evidence into implementation. And it was 2 years later, in 2016, when the National Health Service released also a fundamental report led by Rosalind Rain on complex interventions in health, and to what extent these complex interventions cannot be implemented unless we understand context. And in relation to that, the area where I have been working for the last 20 years has finally a name. And I'm very happy, because when the people were asking me, what are you doing? I was doing this thing, this other thing, mapping and policy and all that. And so my colleagues just turned my back and went to see another person, because the last thing you are supposed to do in academia is work in many areas. I can say that I am working in health ecosystem analysis now. And this new area has several things. It's an understanding of the behaviors and lifestyle of the people living in a region, in an area, to relate it to the availability of clinical care, of service, of care support, and to relate it to the social determinant, the social and economic factors that are happening in this area, but also taking into account the physical environment, that it's critical to understand what is happening. So we are engaged in development this whole new area of health ecosystem research at ANU. We have developed a new unit in our center, the Center for Mental Health Research, that is called the Visual and Decision Analytics Lab, where we are working with health engineers, with mathematicians, with infographers, just to understand the context, to give meaning to the randomized control trials we are used to use in evidence-based medicine. And one of the things is that we are working in a very complex environment. And complex is related to uncertainty. There are things that we don't know, and we may never know, because when we have collected the information, it has already changed in the environment, and where there is a lot of ambiguity. And we have to lead with that when we are using evidence for planning. And the things we have found is that we need to collect information on the framework, what are the taxonomies, the logic models, the conceptual map of the care provision in this local area. And the problem we have come out to identify is that we lack a framework of mental health care in rural and remote areas. We are trying to apply frameworks that have been developed in urban areas, and they simply do not work. We really need to develop a whole area of research for understanding properly the rural mental health context. And this is a major task that has been recently promoted also by the National Mental Health Commission, where they have realized as well that we need to develop that framework of rural mental health. We need to understand in a standardized way the health ecosystems in rural areas. We have to understand what are the agents that operate in this environment, the consumers, the professional, the teams and the organizations, and how they are connected. When we have systems that allow us to understand the conceptual map, the jurisdictions, and the geographical information system of the areas, to apply epidemiology, analysis of provision of care and service utilization, and understand the connections, the connectivity of all these things, we can develop decision support systems that are useful for evidence-informed planning. We are doing that already for urban health, and there is a whole international strategy in this area, but we lack it in rural mental health. And the basic problem is that when we try to compare services, either in rural or urban areas, we come across two major problems in health service research. The first one is called the commensurability problem, and it's related to the units of analysis. When we are comparing hospitals or community mental health centers, they are very different. The name does not explain the activity they are doing. You who are working in rural areas may understand the difficulty to compare what are the rural hospitals in the Northern Territories, in some areas in Western Australia, to a hospital in Melbourne. And at AIHW, they are counting this as a whole set, and they are completely different. You cannot just analyze properly and try to use this for resource allocation, for funding, for policy planning, because they are different. And we have to be aware of this difference, and they are particularly relevant in rural care. So we need to identify a unit of analysis that can be compared across jurisdictions, across states, and across countries. And we identify that as what is called the basic stable inputs of care that defines teams, clinical teams, where you have a group of professionals that on a routine basis provide care for a specific target group of patients. The other problem is the terminological variability. This problem we have with the names, we are talking about hospital, medical homes, crisis houses, day hospitals. What are we talking about? Are they the same thing if we are comparing it through Australia? How the terms are used in New South Wales or in Western Australia? They are used differently, and we are coming across this problem every time. So we need a taxonomy, a classification that can allow us to make this comparison at national and international level. And that's the way we worked out, when I was in Europe, a system that allows us first to understand what happens with these care teams at the microsystem level. Identify them. For instance, we go to a hospital and we identify not the hospital as a whole or the Department of Psychiatry. We identify the clinical teams, the care teams that are providing care. We label them with the international taxonomy, this classification, and that provides a series of codes. For instance, here are services for adults that provide any type of mental health care in a subacute setting for justice. And we used not the name of the service, but the international code to make the comparisons across different areas and to map and geolocate the service provision in an area. Here is the map of psychological distress in Canberra, and we can lay in another layer with the service provision, with the fragmentation, the social fragmentation, any type of index. And in doing that, we have been able, since 2015, to map the services of half of the PHNs in Australia, and we are covering around 47% of the population of Australia. We already have these maps. Most of them are in urban areas, in Melbourne, in Sydney, in Perth, in Canberra, or in Brisbane. It's more difficult to get funding for mapping rural areas. As a matter of fact, we started it with a seed funding from the Mental Health Commission of New South Wales and the cooperation of the group of Professor David Lyle in Broken Hill. And we were able to release the first map in rural Australia, the Integrated Mental Health Atlas of the Far West in New South Wales, and then the PHN of Western New South Wales provide funding for mapping this area as well. And later on, we had funding from WOFA, from the Primary Health Network in Western Australia, to map not only Perth, but also regional Western Australia. And what these maps provide is basic information, visual information on the social determinants that are relevant for mental health and visualize what are the characteristics of these indicators and how we can geolocate and visualize the services that are in the area. We provide in this donut image, the second one, what is the balance of care between social and health care, hospital and non-hospital care, etc. We provide the name of the service, the type of international codes that this service has, the full-time equivalents that can be associated to the care team, where it is, what is the area of coverage, and then we provide a spider web with the general pattern of care at local level. This is, for instance, some of the data of Western New South Wales on psychological distress, suicide, rates of disadvantage, people needing assistance. Whatever indicator we are asked to visualize in the area to support context analysis for evidence-informed planning. Then we can geolocate the care teams that are providing a specific type of care, making this type of international code. So we are able not only to study the accessibility to these services, but also to compare areas. We can compare Western New South Wales and Western Australia, or what are the services here with the services in rural areas in Norway. This is, for example, the type of information we are providing, the number of care teams that we have identified, the types of activities they are providing, that's at the upper part, usually, particularly in rural areas, what we have is a care team is providing one main activity, and the variability of activities that are provided in the jurisdiction. We can just see what is the proportion of services that are providing residential care, daycare, outpatient, information, accessibility of self-help, and then we can study the balance of care and compare it across different areas and understand the workforce capacity, not related to a whole department, but to these functional groups that are providing care and that can be compared across areas. And then we can study what is the balance of care between health and non-health or NGO care or social care in one area, and what is the work capacity in these groups. And then we provide these patterns of care. Here we have 25 groupings of types of care that are very significant. In the upper part, residential acute, non-acute, alternatives to hospitalization, daycare provided in the area, outpatient care provided by the health sector with a health component, mobile and non-mobile, the same in the social area, mobile and non-mobile, accessibility to care, care coordination, and other aspects to improve accessibility, and the community residential support housing or residential care in the area at the light blue at the top. So then we analyze what are the number of care teams per 100,000 inhabitants that are providing this type of care. We can also apply that to the capacity of in beds or in places or to the full-time equivalents. So we provide the standard information on what is the system. And here we see the difference in country Western Australia and in Western New South Wales in green, and in yellow country Western Australia. What is the type of care? We see that most of the care is related to outpatient care with some differences in the provision of health care that are quite significant between country Western Australia and Western New South Wales, and a low level of provision of hospital and residential care, and a general lack of daycare in the system and accessibility or coordination services. But if we look at what happens in different regions, for instance, in Western Australia, we see that this general pattern, it's when we move to the local level, it's very different. At the top left part, you have the service provision in the Kimberleys, and it's in gray, so I see you cannot see it very clearly, but we see a very significant amount of outpatient health care in the area, and a significant amount of hospital care provided here. If we compare Kimberleys with a neighboring region, the Pilbara, where we see that the Kimberleys is the provision of services in the Kimberleys is quite significant when we compare it to the provision of services in the Pilbara region. And something similar happened, not to this extent, if we compare the Great Southern and the Midwest in regional Western Australia, where the availability of residential and hospital care is higher in the Great Southern, while there is a huge amount of social care for mental health problems in the Midwest. What is better, this model, this other model, this other model? We have to have this information and start to link that to service utilization and key performance indicators. And the other aspect is that the key performance indicators that we have been developed for urban areas. They do not work for understanding and monitoring health in rural areas. Then we have the same pattern if we compare the Far West and Western New South Wales, where again we see some differences in the care provision in Western New South Wales if we look at the local level. And this is a pattern of rural care, comparing care in Western New South Wales in blue, in Western Australia in orange, in the Pyrenees in Spain, and in the north part of Norway, the area of Trøndelag, that it's in yellow. You may find that there are differences in the way the care provision works in these 4 areas of the world, and that there is a significant number of daycare provided in Trøndelag in Norway. It's a benchmark area in Europe, and a huge number of healthcare provision in this area in comparison to the others. But we see a pattern here that though there are differences, if we compare it with other areas, for instance, here is the comparison with drug and alcohol, we start to see striking differences. This is the patterns we presented in Western Australia and in regional Western Australia and Western New South Wales, in the pattern of provision of services in drug and alcohol in Western New South Wales is very different to the provision of mental health care, though they may have very common needs. We again, if we compare urban care and rural care, we have a completely different pattern. We are talking about another thing. It's not the case in this equity issue to replicate these models that we find in Perth, in Greater Sydney, or in Canberra, in the rural areas. We are talking about 2 things, 2 very different things. And we can see that because if we compare cities, Barcelona, Bilbao, those are benchmark models of integrated care in Europe. Helsinki is another benchmark model. And the whole area of Greater Sydney, we again identify a type of pattern of care that is very different to what we found when we compare it to Norway, Spain, and Australia here. We are talking about 2 different types of care systems. It's something more than just there are less services in the rural areas or not. If we are going to benchmark areas in the world in rural health, we find a similar pattern that is very different to urban healthcare. If we compare it to the workforce capacity, we start to see striking difference. Here we are comparing the Far West in New South Wales and the services in the northern part of Norway. The major and the striking difference is what we compare the workforce capacity in the non-health sector between what is this sector in Norway and what is this sector in the Far West. In this other sector, there is no professional staff, highly qualified, providing care, while there is in Norway. If we add a comparison to what happens in urban areas, and here is in Canberra, we see, again, a completely different pattern of the full-time equivalence of the characteristics and the profiles of the professionals providing care in urban and rural areas. And the problem is that this healthcare ecosystem approach that tries to provide contextual meaning to what we know is that this is not providing solutions. It's just raising new questions. We understand what we call the stool model of community mental health. We have daycare, outpatient care, hospital care, and community residential care. Those are linked by care integration, and we are measuring the robustness of this stool. And how we should look at the daycare system in a rural area. What is the role of hospital and residential care in these rural areas? Those are questions that have been not sorted out yet. And the idea is how we add knowledge to the local system for decision making. And one thing that happens is that we compare Western Sydney and the Far West. The demands were the same. We want more services. We have very few services. And particularly in Western Sydney, there was related that we need more professionals. While in the Far West, it was more related to a higher number of services. And while what we found is that there were not real problems in the number of professionals in Western Sydney, the problem was structural organization of care. While in the Far West, the main problem was in the workforce capacity. So if we have one answer for Western Sydney, is be very clever in how you deliver and develop new services. If you have to develop an answer for the Far West, you have three main priorities: the staff, and the staff. It's a matter of professionals that are there, how we sustain them, how we motivate it, and how we make a flexible and capable system that is based on professionals. And this is related to how the things are happening at the world scale. There is a global strategy supported by WHO on urban mental health care. We are part of it. We are providing information in urban mental health care in Europe, in Australia, in the Americas, and we are collecting a great amount of information how the service delivery system works in urban areas. And there is a lot of money for that. But the problem is that we will need a similar strategy, global strategy on rural mental health. We are starting to have very striking information on the care system in rural areas in Australia and being able to compare it to rural areas in Europe. We are just starting to get the contacts in the Lapland region in Finland to analyze service provision there. The Mental Health Commissioner of Canada is interested in mapping Labrador, and we have contacts in Denmark for mapping Greenland. We need, or in Chile, the Mapuche population in the Bio region in central Chile. We are talking about an international problem. Rural health is not a problem of a single village. It's a general problem for the world. In 2008, for the first time, there were more people living in urban areas than in rural areas. That does not mean that we have to focus on urban areas. On the contrary, we have to be very careful and understand better what is happening in rural care. So, conclusions: health ecosystem research is a priority in rural health policy. Rural health care is intrinsically different from urban health care. When you are a policymaker, you have to have two heads, one for urban, another one for rural. And we need that. We need to understand that rural health is different, and we cannot apply the urban health principles or guides. An international framework of rural mental health is urgently needed, and this is related to developing local key performance indicators that are relevant for rural and remote areas. The equity analysis is not an analysis of urban and rural. It's an analysis across rural areas. We have to understand the benchmark rural areas and how we translate it into implementation in other areas. The disparities exist even in jurisdictions within the same state at rural level, and we need these maps. The disparities exist also in the patterns of healthcare in related areas, as we have shown in mental health and drug and alcohol, and there are differences in availability and provision that can be quantified, modeled, and used for decision support systems to support evidence-informed planning. And overall, there is a need for a global strategy on rural mental health. Thank you.